Good afternoon.
Good luck.
Thank you for the organizers for inviting me. At my stage of career, it's a real great pleasure to be invited by students. Doesn't happen very often, so I'm really grateful for this opportunity. We in the US have to disclose the relationship with industry, and I do have some. So if there is something with regards to like new software developed at Mayo Clinic ever mentioned in this presentation, take it with a grain of salt. It's not going to be. I guess a lot of students are from Croatia, so I just tell you a little bit about myself, how I ended up at the Mayo Clinic. So I grew up in Sarajevo and really played punk music. But at the time of the third album, I found a real passion. You can see me already with a white coat examining a boy. And after that, I quit playing, and I devoted all my life to medicine. I bought 2,000 pages Harrison's and actually read it from cover to cover. Spent first few years after medical school doing emergency medicine, and as a child from a mixed marriage, ended up like many others across the ocean in North America. So objectives of our talk today is to tell you a little bit about the novel communication technologies that we use today for international critical care education, quality improvement, and research, including social media, video conferencing, cloud computing, and online data capture, and give you 3 examples of what my group have been doing in this area. The motivation for our work is related to priorities that US National Academy of Medicine brought up in the past 20 years. And the key problems are not like designing a new molecular biology, but improving diagnostic care, allowing people to die with dignity. And all of these 3 are exponentially high problematic in a context of critical illness and in low and middle income countries. Indeed, in critical care medicine, high quality supportive care is the most important outcome determinant, including for COVID-19. That includes both good life and good death. And there is a huge variation in care and outcomes unexplained by severity of illness. And so you need a structured scientific approach to clinical practice, which takes into account disciplines like clinical informatics and implementation science, none of which at the time I was in medical school were taught. And most people, I don't know how much of that you have today, but you will need it. So one of the huge challenges in medicine is information overload. It's like medicine is like ink blot, like Rorschach. You can easily see patterns that do not exist. And from clinician to charlatan is literally one step away. So it's essential to distinguish relevant from non-relevant. And the fact that you did something and the patient got better means nothing, because the patient might have as well gotten better in spite of your intervention. So we have had an interest in how you actually prioritize relevant information. So you pick one, you ignore things like troponins and IL-6 and D-dimers and procalcitonin of this world, and you focus on what really matters, prioritize is displayed in your head, in your model, and on a computer in electronic records in a way that you can understand what really is going on. And you can learn from industry that something that takes 25 processes, like transfusion for massive bleeding, 25 steps. If you do each step the best human can do, which is 95% accurate, the whole process will occur only 1 in 3 times. That's why at the Mayo Clinic, only 1 in 3 patients with septic shock are treated appropriately. So you have to reduce steps. You have to get rid of anything that is really not useful. And then those things that are, you have to do them better than humans can do, with standardization, kind of from industry term, Six Sigma. So automation when it is possible, barcoding, let's say, for transfusion, and computerized decision support, checklists, organizational factors, etc. The tools of the trade here is not a microscope, project management for data sharing and for communication. So first, to tell you a little bit about a certain program that started before COVID. So first, maybe I inspire some of you to go to intensive care medicine. So intensive between I like this. We do work with an awesome team of nurses, techs, respiratory therapists, pharmacists, and others. Save a life. So key elements of intensive care is initial stabilization and for our in a humane and compassionate to consideration patients or family wishes and desires. Cognition and treatment of acute injury, and the idea is to implement it in simple. It draws from different topics from ATLS, ACLS, surviving sepsis campaign, different bundles, web bundle, central line bundle, A to F bundle. I don't know how much you're familiar with American abbreviations. So there are a lot of specific issues, but this combines them all into a single approach, which consists of primary survey, what to do during the stabilization of the patient, the point of care labs and ultrasound, and airway, breathing, circulation, disability, exposure measurements, followed by the system-based assessment and urgent interventions, and then finally all of that in a humane approach where you bring the patient out of anonymity as a human being, fulfilling not only physical and biological, but only social, psychological, and spiritual needs, which are all important for someone to go home after devastating critical illness, including COVID-19. We practiced in Simulation Center how to develop these tools. And these are computer tools and paper tools. In many of international settings, the internet is not reliable. You have to pay. This is the nurse in Mexico who has a certain checklist with a laminated card that she wipes off between the patients and uses it appropriately. It can be also in mobile. We did not travel at the time. It's difficult to travel around the world. It's nice, but it's expensive. So we wanted to see, can we do remote training and simulation? And we were able to, so, depending if the users had, something like a sim center, we coached them through that, provided scenarios on a computer, and then they would practice the certain methodology. We had 35 ICUs from 15 countries participating in the program. We use secure online electronic data capture, which minimizes error and is available on a mobile as well as other computers. We collected baseline characteristics, provided online curriculum, remote training, simulation, implementation, about 6 months period, and then we would remeasure the patient data and processes of care. As you could see here, it was just recently published, not only that the processes of care have all improved, except for the head of the bed elevation. That's difficult to check. But hospital and ICU length of stay and ICU and hospital and 28-day mortality were lower in these 35 ICUs of 15 countries using certain approach. We have moved from live simulation to remote and finally to virtual simulation with COVID-19. And we have the curriculum. We have a virtual reality simulation workshop, and for stabilization and for rounding with debriefing after simulation with our learning. This was a course in Rijeka in November here in Croatia. And we couple this with a ongoing collaborative learning program, where we've shown that if in a sustained program, like 1 hour discussions over Zoom, inside you can make changes in structure, process that are sustained, decrease mortality, quite a cost saving. And we have ongoing engagement in the States, in China, Vietnam, Montenegro, Beja, and Peru. Let's talk a little bit about the challenge that COVID-19 pandemics posed. So you get a large number of patients with severe pneumonia, confusion brought up by immense political and financial interests, unjustified variation in practice, fear of transmission to healthcare workers, and again, essential to distinguish relevant from non-relevant. The colleagues from China who participated in certain study organized for us a meeting, and this was on March 17th. We've learned pretty much everything about this disease. I tweeted it, that was March 17, and I think this did a lot of good. Actually, this is how we practice even now at the Mayo Clinic. Everything that was provided there, nothing really changed from for critically ill patients from the initial recommendations by our Chinese colleagues. You are probably aware about the iatrogenic pandemics during COVID-19 that parallel the real pandemics, with a large number of worthless miracle drugs, too early intubation, rush to experimental antivirals and anti-inflammatory treatments, overuse of antibiotics, prolonged sedation, neuromuscular blockade, like got us back to the 80s, bloodletting by endless ABGs, D-dimers, IL-6 and troponins, exponentially high incidence of nosocomial infections, central line infections, VAP, and also infodemia, the real pandemic of misinformation. So to help countries of former Yugoslavia, we developed rapid multimodal critical care knowledge sharing platform for COVID pandemics. The office of WHO in Sarajevo contacted us, and in response, we developed this platform in local languages with providing evidence-based guidelines, which are translated weekly, case-based, and later monthly discussions with local and regional faculty, secure, moderated social media platform for sharing knowledge and combat misinformation that has really gotten quite high clinician engagement and satisfaction, and I hope some lives saved. So this is a Viber group. The last time I took a shot, it was 5,000. Now it's 5,500 members, not only clinicians who are doing critical care, but outpatient doctors and family doctors, and a lot of, as you can imagine, a lot of questions come around vaccinations and approaches from prevention through intensive care and complications and recovery. There's a website with the guidelines, a little bit about how you set the ventilator, because a lot of clinicians were first time faced with a severe pneumonia on a ventilator, and then something of how to simply protect yourself without additional burden. These were these discussions with the regional faculty. A lot of website visitors, This is all way back 6 or 7 months ago. It has grown since time. Quite a learner engagement and really good satisfaction with this program. Let's go a little bit about the research in COVID-19 that our group has done. So March 15, one of my colleagues in, I don't know how much you have first about social media to you. Twitter is really useful for professional networking in emergency and critical care medicine. And clinicians from different parts of the world, mostly English-speaking world, connect through so-called med Twitter and with a hashtag, and it really has is very powerful. So my colleague from Boston University is asking, wouldn't it be nice to have a harmonized registry to ask important non-randomized clinical trial questions? And as you can see, I answered the same day, and then that evening there was a phone call with us and with Society of Critical Care Medicine to make the registry. 10 days later, it has been launched. Some initial ethics approval were done for data sharing with a catchy name, Viral Infection and Respiratory Illness Universal Study, or VIRUS, under the support of Society of Critical Care Medicine. As you can see here, from the conception through the first 16 sites having ethics approval and first 10 patients enrolled took only about 2 weeks. And one thing that we are proud of, we developed the real-time or near real-time dashboard, international, with participating sites. Now it's over 300 sites. This is also delayed, and 70,000 patients in a database with a real-time understanding of what's actually going on, from demographics and race and ethnicity, the top symptoms, the needs for life support interventions, duration of stay, ICU, hospital. And then, as you can see here, of all hospitalized patients throughout the world, about 21% dies in a hospital. These are not just intensive care patients, anyone who gets to the hospital. And as you can see here, only half of them actually goes home without assistance. So just a little bit of something for those who are COVID deniers. And you can click, if you just search SCCM COVID, you will get to this dashboard, and you could follow these changes. As you can see here, the dashboard is looked, obviously the pandemic was heaviest in the United States, and there are most users there. However, the entire North and South America, Europe, Middle East, South Africa, Asia, and Australia have been looking at this dashboard for information. We published some first formal studies from this registry on 20,000 patients who were critically ill. You can see the spectrum of mortality depending of needs for mechanical ventilation, plus minus vasopressors, plus renal replacement therapy, and quite a spread of mortality for the sickest patients around the world. As you can see here, that mortality variation goes from less than 30% in some centers to more than 70%, adjusted for age, severity of illness, and pandemic resources, including drugs, which is really striking, because this is a single disease and single virus, and such variation is related only to the way how we practice. And that led, this is the last slide, to Learning Collaborative, where we do in the United States something what we have done in the Balkans, but on a larger scale with the multi-institutional knowledge sharing collaborative, where we share tricks and tips of how you actually do the best possible with the most severely affected patients with COVID-19. And I'm happy to, I hope I didn't get too far. We have, I think, about 10 minutes for questions and answers. I wanted to share this with you, so maybe some of the things we went over relatively quickly. So you have this recorded, and I'm happy to share the PDF of this presentation for those who need.